Good afternoon, everyone, and welcome to today's mini virtual conference, Design Your New Normal, Strategies for Self-Care. I would like to take a moment to thank our presenting sponsors, Greenwich Biosciences and SK Life Science. This is Susan Welby, Director of Community Education and Engagement at the Epilepsy Foundation, New England. We are so pleased to have you join us for this program on mental well-being for those living with epilepsy. We have 4 wonderful speakers today, and I would like to thank them for giving their time and expertise to bring this information to you. Some housekeeping tips. Attendees are all muted. You may type your questions in the panel for the speakers to address at the end of their presentation. Please remember to keep your questions general in nature and not include any personal medical information. I would also like to acknowledge Biocodex, ASI, Neurelis, and UCB for sponsoring this conference today. I would now like to introduce you to my colleague, Christina Vilardi, the Rhode Island Field Service Manager, and she will introduce our first speaker. Christina?
Good afternoon, everybody, and thank you so much for joining us this afternoon. I have the pleasure of introducing our first speaker, Dr. Seth Margolis. Hi, Seth.
Hello.
So Seth is joining us today. He's a neuropsychologist. He works at Rhode Island Hospital. He is part of the Comprehensive Epilepsy Program here in Providence, Rhode Island. And I'll let you take it away, Seth.
Okay, thank you. I'm just going to try and figure out how to share my screen so you can see my slides. And if anyone happens to know the best way of doing that,
I can see your screen. I'm able to see your screen.
So I have 2 screens. Do you see the slides now?
Oh, now I do. Okay, you just needed to, yep, we can. So if you just maximize them, that would be great.
Are you able to see the slides and not see my video now?
We are seeing both your video and the slides.
Okay, so let's see. I'm going to move some stuff over. How about now?
I can still see both.
Still see both. Okay.
Right up in the top, if you turn off the little green, unclick the green bubble that has the little camera picture.
There we go.
So now it's just the slides?
Yes.
Just the slides, yes.
Wonderful. Okay, the beauty of being the first speaker, I suppose. Okay.
Absolutely.
Well, thank you very much to both of you for inviting me and having me, and all of you for your interest in today's content. You know, these are very unprecedented times, and I hope you're all safe and well and healthy and excited for a lot of interesting talks this afternoon. So without further ado, I'm going to get into mine, which centers on understanding and coping with stigma in epilepsy, a topic very close to my heart. So I want to start by just emphasizing that historically, epilepsy has unfortunately been a stigmatized disorder. This is a quote from a researcher that I think really captures something that is true and simultaneously unfortunate about the history of epilepsy. That the history of epilepsy can be summarized as 4,000 years of ignorance, superstition, and stigma, followed by 100 years of knowledge, superstition, and stigma. And what I think that gets at is that no matter how far we come, there is still, you know, some rampant misconceptions about what it means to live with seizure disorders and the implications of that or lack thereof for someone's quality of life and ability to function. And, you know, I'm here to just sort of shine a light on that and hopefully make some positive change for the future. So epilepsy, as I don't need to tell folks from this audience, is a common and costly condition. It affects between 1.8 to 2.5 million adults in the US and more children. About 150,000 new cases are diagnosed every year. By age 20, 1 out of every 100 persons in the US will develop epilepsy and that will increase to about 3% of the US population by the time individuals turn 80. So it's not an insignificant number of people affected. Per year, the US spends about $12.5 billion on costs related to epilepsy, and there is research to suggest that indirectly, social and functional implications of seizures account for the vast majority of these costs. Now, what do I mean by that? What I mean is that epilepsy can lead to difficulties with functioning and participation in society that can lead people to end up needing to have costs spent on them at a societal level. And so more specifically, people with epilepsy are unfortunately less likely to graduate from high school, to drive, which is a huge barrier to independence for many, as well as work in settings where employers would be accepting liability for injury should one occur. And so it's not surprising that unemployment rates are high for people with epilepsy even before COVID-19, with about half of people treated in tertiary epilepsy centers like ours being unemployed. Other cohorts have reported that a quarter of people were only working full-time, and that 42% of people that were working were working for pay, relative to 70% of aged matched peers without epilepsy. And so that goes even deeper. If you think about the people who are working, those individuals with epilepsy missed triple the number of work days due to illness, which amounted in that study to nearly $10,000 in lost wages that year. Not insignificant at all. And household incomes of people living with someone who has epilepsy generally are lower than the average household income, at least back in 2000 when those data were collected. The effect of epilepsy also spreads to people's attitudes, so not just their pocketbooks. 40% of people with epilepsy have endorsed fear of discrimination in the workplace, and some of these concerns have been reinforced by documented examples of negative attitudes held by employers. People with epilepsy also have endorsed feeling discouraged from aspiring to greater vocational heights. And there is a tendency for people with epilepsy to work in less skilled professions. And so you can kind of understand how the monetary implications may stem out of some of these perceptions or misconceptions, both by employers and those seeking employment. Psychosocially, at a more intrinsic level, there are also quite a lot of difficulties that present in people who live with seizures. So people with epilepsy do tend to get married at lower rates than people without epilepsy, and there are plenty of mental health concerns to speak of. Poor self-esteem, reduced self-efficacy, or a feeling of what I call can-do-itness. Increased social isolation is also quite common. An introverted behavior or a tendency to withdraw socially. And increased neuroticism, which is really just a characteristic tendency towards being sensitive to distress or being more stress reactive. And increased rates of depression and anxiety symptoms are also quite common. Stigma beliefs are also intertwined in this, but maybe a little less clear than some of these other things. So when we are talking about epilepsy and its stigmatized nature, it's important to kind of separate that from discrimination. Now, discrimination against people with epilepsy stems from its cultural history, which I mentioned. But in the modern world, even though a lot of discriminatory laws have been abolished, we have to think about the not too distant past, where in 17 US states, up until 1956, people with epilepsy weren't allowed to be married. And the final state, Missouri, to reverse that law only did so in 1980. Now, in some parts of the world, epilepsy still remains a viable reason for annulling marriages. And if we think even more recently, something that we really treasure today, the Americans with Disabilities Act, that was only ratified in 1990. Now, all of these things being in the rear view is very positive, but despite societal advances, internalized or perceived stigma still remains pretty common in affected individuals. So now, is there a difference between stigma and discrimination? If we think about the definition of stigma, some sociologists have considered it a loss of status or power resulting from the separation of the stigmatized individual or stigmatized group from the general population because of some characteristic, some mark that has been culturally defined as different or undesirable. Now, if we talk about perceived stigma, this is really referring to the internalization of feeling embarrassed, in this case about having an illness, or about the fear that one may encounter discrimination. Now, it doesn't mean that someone isn't discriminated against in real life. I think that that is definitely true and it happens, but stigma that's internalized does not require that. 42% of young adults with epilepsy have endorsed believing that the general public holds a negative view of them. 41% said that this belief negatively impacted their self-concept or how they viewed themselves. Stigma may lead to maladaptive coping like social withdrawal, secrecy. For example, 20% of people with epilepsy have denied having epilepsy at some point. Not surprisingly, stigma beliefs can negatively impact quality of life, and it's also been linked to psychiatric symptoms like anxiety and depression, being worried about the implications of seizures, as well as social restriction or behavior restricting anxiety. So in this paper, myself and my colleagues really looked at anxiety disorders in a racially and ethnic minority sample of patients with epilepsy. And what we were able to demonstrate was that nearly half had a diagnosable anxiety disorder, which is more than just saying I feel anxious. It's saying that it's interfering with their life in a meaningful way. More than a quarter of those individuals reported moderate to severe levels of anxiety. The most common disorders were agoraphobia, or fear of being away from home or leaving the home unaccompanied, as well as social phobia, which is fear of ridicule, criticism, or embarrassment, as well as others which were a little less frequent. But among the 30% who had 2 or more anxiety disorders, nearly 90% had agoraphobia, which I find remarkable. Those with an anxiety disorder tended to have convulsive seizures, report greater seizure worry. They checked off more physical and mental symptoms of anxiety on a checklist, but they also endorsed higher levels of perceived stigma. And then if you try and predict who had an anxiety disorder or who didn't, like flipping a coin, you'd be right half the time, okay? But if you model all of these things together and you consider all those risk factors in one statistical equation, you'd be right in deciding who has an anxiety disorder nearly 3/4 of the time. But the only predictor that was uniquely related was stigma, meaning that there's something specific about stigma that is unrelated to the other things that is really driving anxiety disorder. Now, stigma can also lead to poor self-management in epilepsy. So in this graphic, you can see that stigma leads to difficulty accessing information, which leads to difficulty implementing behavioral skills necessary for epilepsy self-management, which then leads to poor adherence to anti-epileptic drugs. Motivation is listed, but that actually fell out of the model. And I wonder if beliefs are really driving these difficulties. We found in some work that we've done in the past that negative beliefs about anti-epileptic drugs correlated with worse anti-epileptic drug adherence. And we've also found in another study that anti-epileptic drug non-adherence is unfortunately common. In this study, electronically monitored anti-seizure medication was only taken by participants correctly 72% of the time, with an average of 11 doses missed over 1 month. Now, this is important for stigma because if you see, seizures as kind of driving stigma beliefs, or seizures making it so that you're less engaged in life, society, relationships, right? You think about that then ramping up stigma beliefs. I'm different. There's something unusual about me. I can't, fulfill my goals. And then that leads to more avoidance, added stress, which we know brings on seizures, and then leads to reduced engagement further. And often in the periphery, you see discrimination is acting on all of these things and kind of driving this unfortunate process. So we have to do something to drive a wedge in here to stop these things from happening. Now, it's hard to figure out why stigma happens or what to do about it. I think oftentimes people don't even know that they're experiencing stigma beliefs, and some of this may relate to the fact that I believe stigma beliefs are related to or stemming from our personalities in some cases. So if we think about the stigma personality link in people with epilepsy, we have to first take a step back and think about what personality is. So this refers to characteristic or normative variations in how people think, feel, react, and relate to others. Personality is biologically determined to some extent. You guys are probably, like your parents, who were probably like their parents, at least to some degree. But personality is also heavily influenced by meaningful life experiences. And so if we think about living with seizures, which are unfortunately an unpredictable episode that we just kind of don't always know when it's going to come on, or we think about everything that I described earlier about barriers to social advancement and independence causing us to maybe modify how we approach relationships, life, or the pursuit thereof. And then we think about the other side of the coin, right? Enacted discrimination and negative experiences that we've had in interacting with people and society. That can then lead to internalized stigma, which then becomes sort of part and parcel of how we, again, think, feel, react, and relate. And indeed, in this study, we found that people with epilepsy who were scoring more highly on the personality trait of neuroticism, which is really just talking about, again, proneness to distress or a tendency to be stress reactive. People with epilepsy who are more prone to distress were more likely to report stigma, right? And more likely to report worse social outcomes. But stigma really accounted for this relationship here, so that more stress reactivity led to greater stigma beliefs, which led to worse social well-being. The same was true for the personality trait of extraversion, or if you flip that on its head, introversion, such that the more introverted someone is, or the more someone preferred solitude or tended to withdraw socially, the more likely they were to endorse feeling stigmatized because of epilepsy. And then the more likely they were to endorse worse social outcomes. And the relationship between extraversion and, in this case, better social well-being fell away because it was really accounted for by stigma beliefs. It's explaining the link. There's also a relationship between how flexibly people think and their personality and stigma. And so in this figure, let me just unpack this for you. On this axis, the x-axis, we have executive functioning, which refers to people's abilities to generate ideas, think flexibly, to solve problems, okay? And then, 0 is average, and anything over here is above average, anything over here is below average. This is perceived stigma. This is, I don't have a lot of stigma. This is, I do have a lot of stigma beliefs. Okay, and basically what you can see here is this is people, the blue line, with an average level of stress reactivity. This is people with low average stress reactivity, so they're kind of unfazed. And then this is people with high stress reactivity. And what we can see is that people with better cognitive flexibility, or the ability to, again, generate ideas, think flexibly, and solve problems, who are, endorsing an average level of stress reactivity or a low average level of stress reactivity, those unfazed people, they are better able to resist feeling stigmatized. But the people who are highly stressed, there is no benefit from their cognitive flexibility skills on perceived stigma. So they don't enjoy that same buffer. Now, this can lead people to get stuck with stigma. And so I just want to highlight a couple of examples of self-talk that I've heard people report over the years, patients of mine. So this person said, everyone else in my life is going on with theirs, but I'm stuck because of epilepsy. Again, relating themselves back to their peer group and comparing themselves and thinking that they are getting, negative results where everyone is getting positive. Since my seizures started, I stopped school and stopped working. I feel like everyone is judging me, and I'm only comfortable around people I've known for many years. So again, thinking that there's criticism out there and that they don't have the ability anymore, the capacity to pursue what it is that they previously enjoyed or what they want out of their relationships and life. My vagus nerve stimulator magnet makes my face and neck twitch, so I don't go out because I won't swipe it in public. I'm also self-conscious about bruises and scrapes from seizure-related injuries. So thinking people are judging them negatively because of things that they perceive as, outwardly unpleasant to others. My supervisor saw me taking my anti-epileptic drugs, and now she thinks I'm on drugs. I can confirm that this patient never actually talked to the supervisor about whether or not they thought that of her. I used to play organ at church, but since I had a seizure at Sunday service, people look at me differently. I won't go back. Again, never confirmed that this was indeed the case. And this was someone who really felt at one with that community and now is restricting their behavior or willingness to engage with that group because of this unfortunate experience. Last one, I can't ask the professor for accommodations. He'll think I'm stupid. So again, sort of a vicious cycle, not being able to access or avail oneself to services that are there for them due to a perception that it will come back against them in a negative way. So stigma beliefs are common in epilepsy. I hope I've made that clear at this point. They may overlap with enacted discrimination. Indeed, I think they do. But they may also stem from personal attitudes and tendencies. And stigma beliefs can reach a level where they are causing clinically significant distress and anxiety and impair social and occupational functioning, thus rising to the level of disorder. And so I really believe that novel approaches to intervention are needed to address stigma beliefs head on for people with epilepsy so that we can stop the stigma. Now, how do we do this? That's tough. I don't have any specific answers, but I do have a lot of ideas. One thing that is notable is that psychosocial interventions, specifically targeting stigma, have not yet worked in adults. Education alone about illness and how it's managed hasn't really worked for stigma outcomes. Peer-led support groups alone didn't really touch stigma outcomes. A combined approach may be worthwhile, and for sure, Epilepsy Foundation of New England has a whole host of support groups around the region, including right here in Rhode Island. We have our Support, Hope, Advocacy, Resources, and Education, or SHARE groups. They meet monthly, and they incorporate both peer support and expert opinion models. Now, this may be less the case since COVID, but it's important to note that in-person formats aren't for everyone. There's research to show and anecdotes to suggest that difficulty in getting to an in-person meeting may be difficult for a lot of people and present a barrier to attendance. But if you think of people who feel inherently stigmatized, they may not be chomping at the bit to go and talk to a whole room full of people about their deepest, darkest secrets. And so there is the potential for in-person formats to maybe not offer the level of anonymity or protection that someone in the throes of perceived stigma might require initially in order to feel like they're in a safe space where they can share ideas and get help. Now, what we're attempting to do is create a program which we call the Rise Above program, which stands for Reducing Internalized Stigma in Epilepsy, a behavioral online video education program to really fill this need. This would be a web-based cognitive behavioral therapy intervention to reduce internalized stigma in people with epilepsy. We have a multidisciplinary research team consisting of neuropsychologists, neurologists, computer science experts that would all partner with industry to develop and pilot this web-based intervention that would utilize stakeholder feedback from individuals like you, patients, professionals, advocates, and family. We would then track usage, usability, acceptability, and satisfaction with the intervention that we develop, and it would be tested in preparation for a larger trial before rolling it out to communities like yourselves. So stay tuned. But if you are interested in learning more when the time comes, I would encourage you to please email me, and I believe that this is going to be recorded and that slides will be made available. This is my email. I'm always happy to take names down, talk to you more about it when the time comes. We're not ready to start this yet, but I'm hopeful that we will be in the future. In the meantime, the Managing Epilepsy Well Network has a whole host of online options that may be especially useful during the pandemic, but I think are just useful for all the same reasons that I outlined for people who deal with these kinds of tendencies and barriers to good quality of life in the epilepsy community. So here's the link for the Managing Epilepsy Well Network. This is sponsored by the CDC. Basically, the Managing Epilepsy Well Network has rolled out a variety of these web-based intervention tools to help people access needed information and services. Project Uplift is one of them. It's designed to help people manage depression. WebEase is another web-based intervention geared toward helping to promote self-management skills. Project Mindset is a tablet-based intervention that is intended to promote practical skills in people with epilepsy. And Hopscotch is a telephone-delivered intervention to help people work around memory difficulties and apply strategies to everyday life to promote better quality of life. There's also a whole host of anti-discrimination campaigns and resources out there that are really geared toward helping to promote awareness about epilepsy and those affected by it and those who love people affected by it, so that folks can be, in a community where people are increasingly stomping out discrimination. And there are all sorts of local resources available to individuals here in Rhode Island, including the Career Navigator program. There are dial-in and in-person support groups, which I've mentioned, free educational trainings to school personnel and within classrooms. There's also educational advocacy groups, parent information networks, and career centers, Office of Vocational Rehabilitation here in Rhode Island, and the Disability Law Center in Rhode Island, all terrific resources to help people, again, work around barriers to fulfilling their goals and increasingly making stigma something that is really in the rear view for them. And that's my presentation. I'm happy to take questions if there are any, and if, like I said, you have any interest in reaching out for really any reason, I'm very accessible, very available, and always interested to help. Thank you so much.
Thank you, Dr. Margolis. That was wonderful and really illuminating. There's no easy, simple answer, and I like that you're coming up with a program that will combine multiple avenues, including cognitive behavioral therapy, to intervene with these persistent beliefs and stigma. Having facilitated support groups for many years, I do recognize those people who are stuck in place. Month after month, they come and they talk about the same issues and aren't moving on. And I'm always saying, okay, how are we going to get through? How can we get through to them to move them on? So I find this very, very helpful. And if you will kindly just email your slides to me, I will ensure that everybody receives a PDF of the handouts, because you included some excellent resources. And I'm happy to let you know, if you have any patients, I did get trained last fall in Hopscotch and have been meeting with clients. So I am starting. I do see one question here, Dr. Margolis. So before we move on to Dr. Tremont, let me see. Stephanie asks, how do you know if the stigma feelings are from the coexisting mental health issues, which also carry stigma, or from the epilepsy? How do you know which caused which?
I don't know that we can. I think that they're highly intertwined, and they may ultimately manifest in the same way. So if the issue is that you're having, significant psychiatric symptoms, or you've had co-occurring epilepsy and psychiatric symptoms for so long that now you just can't disentangle them, I think the ultimate step, if you feel like you are prevented from seeking out opportunities, or you're prevented from pursuing things in a gradual way that are going to get you closer toward your goal, just to think behaviorally, think practically, and think, all right, what's the thought that I'm having right now that's preventing me from taking step one, or even considering step one, and then start there, and then gradually moving toward that. Now, our program will incorporate a lot of practical, flexible skills that can be applied to a variety of situations in hopes of helping people really think about it concretely and make the stressful feelings that come up during those thought exercises a little bit easier to tolerate, so that people can steadily start making some gains and then find out, all right, well, this was a success, and so I'm just going to keep going, or this went wrong, but here's why it went wrong. It wasn't because of what I originally thought. It's something different, so I need to tweak it. I know that doesn't specifically answer the question, but I think that overall, we have to just keep moving forward and not getting stuck, because the more we get stuck, the more we incorrectly attribute the lack of momentum to what we maybe are preconceiving as something that's wrong, either with us or people's perceptions of us, when I think a lot of times that's not the case. Sometimes maybe, but I'd say most times probably not.
Great. Thank you so much, Dr. Margolis. I do not see any other questions. So again, I want to thank you for your time. And I'll bring Christina back to introduce our next speaker, Dr. Jeffrey Tremont, while I change screens. Thank you so much for joining us today, and have a wonderful weekend, Dr. Margolis.
You as well. Take care of yourselves, everyone.
Thank you so much, Dr. Margolis. And I forgot to mention too that we're excited to have Dr. Margolis also as part of our Rhode Island Council here in Rhode Island. So I'd like to invite and welcome Dr. Jeffrey Tremont to present to us about stress, seizures, and stress reduction. He is also from Rhode Island, part of the Comprehensive Epilepsy Program at Rhode Island Hospital and the Miriam Hospital. He's the director of neuropsychology. So he is coming to us from Rhode Island. And welcome, Dr. Tremont.
Thank you very much. I'm happy to be here today to talk to you about stress and seizures and stress management. Can you see my screen okay?
Yes, we can.
And you can hear me okay, it sounds like.
Yes, we can. Thank you.
All right, great. So I'm happy to talk to you today about this topic of caring for yourself and stress and seizures. And I want to thank Susan and Christina for inviting me today to talk. What I want to accomplish, whoops, let me just get this screen change here. What I want to accomplish today is to define stress and the stress model, and kind of give you a view of how you can think about stress. I want to talk about the effect of stressful life events and stress associated with epilepsy. Give you a little kind of quick overview of the stress response and how the body reacts to stress, and then talks a little bit about the relationship between stress and seizures. Then we're going to get into some stress management techniques, and I want to bring you through a little mindfulness meditation exercise. We'll try to do this virtually. We'll see how it works. And then talk more about coping daily with stress and kind of strategies and things that you can use to do that. So here's my first, I kind of gave it away because I clicked my screen ahead, but here's my first definition of stress. So you can see this poor little dog. But really, what is stress? All kidding aside, stress is an event that it's stressful if an individual, when they appraise the demands of a situation, it exceeds the resources they have. So this is when an event is seen as stressful for an individual. So this definition takes into account both characteristics of the person and the nature of the event. And stress really comes from this demands and pressure of the recent past and the anticipated demands and pressures of the near future. Everyone has an amount of unavoidable stress at some time, no matter what. Even if we won the lottery, we were perfectly healthy, we had everything we wanted in terms of personal, like family and health and all of those things and relationships, there still would be something to be stressed about. It always happens. And the other thing to think about is that stress, certain levels of stress, can be beneficial. They can motivate us to improve or to do things, but obviously the excess is problematic. So let's talk a little bit about a stress model. And so this is just one model proposed by Lazarus and Folkman, who are some stress researchers. And the idea here is that you have a situation or an event. So it could be, I'm frustrated at work, or there's a lot of work that I need to complete at work. And the first thing that happens is a primary appraisal. So this is something that an individual does, is looks at this situation and says, is this a threat? Is this a problem for me? Do I feel like this is concerning to me? And if it's a threat, if it's not a threat and it's like no big deal, then there's no stress. It's fine. But if this is appraised as a threat, something that is bothersome to me or concerning to me, then you go to a secondary appraisal. And the secondary appraisal, the individuals say to themselves, can I cope with this? Is this work that I have, all this work that I have to do at my job, can I manage it? Is there a way that I can handle it? And if that's true, and I perceive that I can cope or manage this threat, then we would think of this as positive stress. So this is like, probably a lot of us have experienced this, where you have a lot going on, but for whatever reason, like you're able to just go with the flow and you're able to do it and get it done. And so we think of this as this positive or motivating type of stress. But if we do feel like this problem or this threat is that we don't have the resources to cope with it, we really perceive like this is way beyond what we can handle, then we start getting into this negative stress. And this is really what, when we talk about stress, this is what people think, and it's this kind of overwhelming my resources of what I can cope with. And it's not even really whether you can cope with it or not. It's really about a perception, right? It's really about, do we think we can cope with it? Do we feel overwhelmed? And that's an important distinction between, are we actually overwhelmed, or are we perceiving that we're overwhelmed? And we'll talk more about that as we go through some strategies. So just as an example, just to show you, this is a listing of different stressful life events. And so you can see, and they're kind of graded or weighted in terms of how stressful these things are. And, what's interesting about this is obviously the big ones are there. You go to jail, you get a divorce, you retire, you have, medical problems, people die. All of this are big ones, but even little things do create stress. You go on vacation, your hours change at work, you go to a new school, a new job. These things are stressful as well. So, all these little things kind of add up to create stress in our lives. And these are the things that we manage, and these are the things that we want to try to cope with and build resources so that we don't get to that point of feeling like our resources, our demands exceed the resources that we have. All right, so what are some of the specific stressors associated with epilepsy? Well, obviously having epilepsy or a seizure disorder, the unpredictability of seizures can be particularly stressful. I hear a lot from patients I see the need for having to take medication or side effects from medications can be stressful. Uncertainty around the seizure onset. Driving is a big one. Dependency on others and having kind of knowing that people are worrying about you and watching you, supervising you. And then what Dr. Margolis, I know, just talked about, the social anxieties, particularly like around the stigma. And those can be very stressful. What if people judge me or find out, or what do people think about me having seizures or epilepsy? Things like family tension or risk of injury, lack of social support, or even on the caregiver or family side, caring for somebody with epilepsy can be particularly stressful. And we'll talk more about that as well. Dealing with memory and cognitive problems. So there's a variety of stressors associated with epilepsy. And, the way we think about this is on top of your normal stressors. So right now, during this health crisis, this pandemic, we all have that stressor, which is a big stressor for us. And then on top of that, we have our normal, regular stressors happening in our families and in lives and work and all of that. So these things can really add up. Obviously, for children, epilepsy can be, a significant issue related to developing independence, friendships, academics, change of routine, family tension. All of those things are things that can happen with children and families coping with epilepsy. So let's talk a little bit about the stress response. So what happens when your body and your brain experiences stress? What happens? So, this kind of follows through the body and just shows how the nervous system handles stress. So, the nervous system perceives stress. Your brain, you think, I'm stressed, I'm overwhelmed, I don't have resources to cope with everything that's happening in my life. And your brain sends signals to the pituitary gland, which releases hormones. And these stress hormones, such as cortisol, which probably you've heard of, epinephrine, norepinephrine, these stress hormones then travel through the blood and activate the body. And they really are activating the body to prepare for a fight or flight reaction. So if you think about how stress is adaptive, back when we were, roaming the plains as cave men and women, we had threats in our environment. So big animals would threaten us, or we were hungry and we didn't have food and had to go find food. And so our body would have these reactions. We're built to have these reactions to stress, to activate the body, to kind of juice up the body and give you energy. And that's exactly what happens when you experience stress, right? So you get these hormones released that activate the body. Your hearing ability increases, your blood flow to the brain increases, your senses sharpen, your pupils dilate, you sweat more, you breathe heavier, your heart rate increases. All of these things happen to kind of activate your body. The issue happens when we have prolonged stress. So this stress system was designed for kind of a short burst of hormone release, right? So that you could fight, or you could run, or you could, get this animal for food, or you could run away from people who are chasing you, or whatever was happening. It's not really meant for having prolonged release of these hormones and the body having these heightened rate of stress and activity. And so that's where we run into trouble. And so, what are the effects of stress? So, You think about things like the way I divide it here is really thinking about the body, the mind, behavior, and emotions. So stress, as we talked about, has this big effect in the body. In a prolonged way, it can cause things like headaches and fatigue and indigestion, heart palpitations, sleep trouble. On the mind, it can do things like worrying, indecision, negativity, having really unclear thinking. In your emotions, it can cause irritability, aggression, loss of confidence, being very serious and worried, apprehensive, all of that. And then in behavior, stress can lead to things like substance use, like smoking, drinking, feeling kind of edgy, losing your appetite, all of those kinds of things. So stress can really affect all systems of the body. Think of it as, you always think of like the mind and the body, that the mind, just like I showed you in that model of what happens to the body, is the mind influences the body and the body influences the mind. So we feel this stress in our body, we feel this tension and tightness, and then that leads to us feeling this anxiety and agitation, in our minds as well. So in terms of stress and seizures, so kind of moving on, what's interesting when you talk to people, and I'm going to tell you a little bit about a study that was done, stress is really the most commonly reported seizure trigger for people with epilepsy, somewhere between 50 and 80%. Clearly, stress does not cause epilepsy. There are people who have these non-epileptic seizures, or we call them sometimes psychogenic seizures that are stress related in some way, but really stress is not a primary cause of epilepsy. Studying the effect of stress on seizures is difficult because stress can lead to things like sleep deprivation, alcohol use, maybe missing your meds, which can all be associated with increased seizures. Stress, anxiety, and depression are also, they can interact and contribute to seizures as well. So there is some evidence that stress could increase seizure frequency, but it's not that clearly understood. Maybe it's related to hormones, maybe it's related to chemical changes in the brain or inflammation. Just like I said, there is this mind-body interaction. We know that people who have prolonged stress are more prone to physical illnesses, mental illnesses. There definitely is this interaction. So just to tell you about one study of over 1,600 people with a history of epilepsy, they were given a detailed personal interview and a questionnaire looking at seizure precipitating factors, so factors that really triggered seizures. And 53% of people reported that at least one factor may have caused a seizure or felt like it contributed to a seizure, while 30% thought two or more. And the top three factors were emotional stress, sleep deprivation, and tiredness. And another thing to mention that's interesting, one of the most common areas where seizures begin for people, particularly with temporal lobe epilepsy, is in a part of the brain that's called the limbic system, which is where negative emotions such as stress, worry, fear, this is where these emotions kind of originate and are regulated. And so there is this overlap where when people are experiencing seizures, sometimes some of the auras or feelings that they have are related to, the limbic system, are tied to the system. So there is definitely some connection there as well. Okay, so we just talked all about, stress and the stress response and how that relates to seizures and how it relates to, a precipitating seizure and what it does to the body. But let's talk more about stress management, because we all, experience stress to some degree. definitely during this time, in addition to our regular stresses around having, seizures, epilepsy. So let's talk about strategies or ways to manage. And I'm going to tell you about really some different general techniques that can be helpful. So one area is cognitive and behavior therapy. So particularly for people who are feeling a lot of uncontrolled stress, then it really makes a lot of sense to seek out professionals to help you manage stress. There's some regular stuff you can do daily, which I'm going to talk about, but then, there are times, especially if you're very overwhelmed or you're experiencing stress leading to anxiety and depression, that it's important to seek professional help. So one strategy is cognitive behavior therapy. And this is an approach that really examines relationships between thoughts, emotions, and events like seizures. And there is research to show that this can benefit seizures. It can improve depression and anxiety. And it really helps us to understand a lot of kind of automatic thinking or assumptions that we have that we don't really even pay attention to, that trigger thoughts, that trigger emotions, maybe triggering this feeling like I'm overwhelmed or I'm really stressed out. These things can be triggered by kind of these automatic thoughts. And so this type of therapy helps us explore what are some of those thoughts and how do they connect into how we react and what our emotions are like. So this can be a good approach. And there are a lot of therapists out in the community who can provide this type of treatment. Another area that can be really helpful for stress management is mindfulness. And this is a type of meditation in which you focus on present stimuli in a non-judgmental and accepting way. And as I've been kind of mentioning throughout, this really emphasizes the mind-body connection, right? It's really helping us to understand and observe what's happening in the mind and what's happening in the body and really see that connection. And there's evidence that 4 weeks of practicing this mindfulness type of meditation can really improve quality of life and reduce seizure frequency in people who have what's called drug-resistant epilepsy, meaning that people who continue to have seizures despite treatment with medications. So, these can be definitely a helpful approach. And in a minute, I'm going to bring you through a little mindfulness exercise. And there's kind of a relatively newer technique called acceptance and commitment therapy, or ACT, which really combines the two approaches that were mentioned, which is CBT and mindfulness. And I gave a little diagram there that just talks about the different areas that it covers. It has to do with focusing on the present moment, acceptance, kind of letting go of the need to control things, recognizing thoughts, feelings, and emotions, and identifying what's important to you in terms of values, that type of thing. This has been shown in epilepsy to improve depression, anxiety, quality of life, self-esteem, and showed a 50% seizure reduction in about 9 of 10 patients in one study. So it hasn't been studied in a lot in big groups, but it does show to be a helpful technique. So all of these therapies are really something you would work with a professional on, okay? So let's talk a little bit about yoga and meditation. So this is something that can be done on your own. And this, yoga in particular involves breathing exercises, postures, and meditation. This has been shown to potentially affect the EEG, or the electrical activity in the brain, as well as the autonomic nervous system, which is the nervous system that we talked about early on with the cortisol and kind of what happens when we have a stress fight or flight response. The autonomic nervous system is kind of that controlling system that controls whether we fight or flight or whether we're more of a relaxed state. And there is evidence that both yoga and meditation is better than nothing or just general relaxation strategies for seizure reduction. So all of these techniques I've mentioned are good. So let's talk about biofeedback. So this is another strategy where people can learn how to control their auditory or visual feedback and their physiological responses. So in this situation, you kind of get hooked up to EEG or like measuring skin conductance, and then you're given the feedback of what's happening with this information in your body, and you kind of learn to control and train it. This has also been shown to reduce seizure frequency. All right, so I want to take a couple minutes here to do a little bit of a meditation with everybody. So it's a little weird because we're doing this more virtually. If it was in person, it's a lot easier to kind of see what I'm doing and everything, but let's just give it a shot. We'll just take a short little brief meditation. So people might be, I don't know, they could be sitting on a couch, you could be maybe laying down, I don't know where everybody is, but the idea is to get yourself in a kind of a sitting up straight position, uncross your legs, plant your feet. You might, if you're in a chair, you might slide yourself a little forward so that you're nice and straight, you're not slouching. And then just gently close your eyes and see if you can relax your body. So let the hands relax on your lap. Let your shoulders release down and drop. Let your jaw soften. Maybe you can feel your body sink into the chair. Now rest your mind. Okay, your mind's always so active and busy. See if you can let it go a little. The idea here is not to try to stop your thoughts, but to let them come and go naturally. All right. Now draw your attention to the breath. Okay, so see if you can breathe just naturally in and out through the nose. Okay, can you feel the sensations of breath as it comes in through the nose and then out through the nose? Okay, sometimes you can feel maybe like a cool sensation on the inhale all around the nostrils, and then a warmer sensation on the exhale. All right, and as you sit and attend to your breath, you might notice that your mind wanders, or maybe it gets caught up in a thought. This is exactly what the mind does. This is normal. This is what the mind wants to do. So what you want to do is you gently direct your attention back to the sensations of the breath. So you just keep bringing it back gently. You're not fighting with the mind. You just gently direct it back to your breath, to those sensations on your nose. So let's just take just a few moments of me not talking for you to just observe your breath, the sensations in the nose, and if your mind wanders, just bring it back. And now slowly open your eyes, maybe move your fingers a little, move your shoulders around a little bit. Just coming out of that little meditation, just a little connection to your body. So we're using the breath there in that meditation as a tool to help us focus and draw your attention to the breath. So that's just one example of a meditation you can do. There's lots of different meditations. I encourage people to You know, if you on your phone, you can download meditation apps where you can listen to guided meditations like I just did. It can be really helpful. And sometimes you focus on the breath, sometimes you focus on other sensations, sound, music. You can do like a little mantra where we repeat something like breathe in, breathe out. Things like that can be really, really helpful. And it doesn't have to be long. So just like we did, I mean, we did probably like, you know, a minute and a half, 2 minutes of something. Yeah, just a couple minutes, and you can build that up over time, or you could just build that into your day. Meditation can be a really powerful strategy. It's just having some time where you just do nothing and observe how your body feels. It also gives you an opportunity to just see where you're at in your body. You can detect some of these sensations that we talked about. All right, so hopefully you feel a little more relaxed. Maybe we should have done that right at the beginning rather than here towards the end.
Either way, it felt really good, Dr. Tremont. It really did.
Oh, good, good. Glad to hear that. All right, so let's talk a little bit about some daily coping with stress. And so here are just some really kind of hit you with a few bullets about things that are important to do. So really, it's a lot about, you know, coping with stress is a matter of balancing a lot of different things. And so how do you cope daily with stress? So one is to know what to expect, right? Be proactive. Have a strong support network. Consider your attitude and stay active. So so in terms of knowing what to expect, you know, and we're applying this really to epilepsy and to seizures, you want to learn as much as you can about your condition. You kind of know what to expect. You know what to ask when you go see the doctor, things like that. Read books about epilepsy, learn about managing stress, visit websites like epilepsy.com, meet with a social worker to identify resources. Be proactive, you know, so take an active role in your treatment, ask questions, research new treatment options, communicate concerns to your doctors, record seizures to help understand patterns, maybe when seizures that are triggered with by stress, you can kind of identify what those patterns are. I'm sure a lot of you have already done that. Anticipate stressful periods, plan accordingly. Like we know during this pandemic right now with a lot of so much uncertainty happening and everything else that's happening in the world, that it's a stressful time. And so we want to build in as much stress management and coping and time for meditation, for a little exercise. That's really important to build that into your schedule now more than ever. Now, maintaining a strong support network is really important for stress. We know that social support can help. Family and friends can provide support groups. Others with epilepsy can really help you to understand specific stressors. They can get practical information. As I said before, if you feel particularly overwhelmed or you're struggling with depression and anxiety, it's important to have counseling, seek out a professional. That's critical. And, you know, talking about your problems, even if they don't seem like a solvable thing, is important. You know, like when a lot of times for people, if you can put things down on paper, right? You write down, here are my problems. I'm going to write a journal, or I'm going to talk to somebody about it. Seeing it or hearing it can really help you put things in perspective. And as I talked about earlier, a lot of this is about perception, right? Your perspective. And so if you feel overwhelmed, it is a perception. And maybe if you put it down on paper, you talk about it with someone else, it's like, you know what, I can manage this, or I can do X, and begin to do part of what I need to do to manage this problem. And then, you know, considering your attitude. Positive thinking is important. Reframing your thoughts to view stress really as an acceptable emotion, like this is okay. And that, you know, also not identifying with the stress, meaning like I am not the stress. Stress is something that I am experiencing, but it's not what's defining me. Positive self-talk, it can be really helpful. living in the present, so a lot of our time in stress is about anticipating the future, right? Or reliving the past. So we think of depression and anxiety. Depression, oftentimes reliving the past, anxiety, anticipating the future, and so trying to be really right now. And right now, in this very moment, I don't really have stress at this very moment. If I think about what I have to do maybe in an hour or tomorrow or next week, maybe I do have some stress. But right in this moment, I am just talking and listening, and I don't have stress. You want to make time for fun. You want to make sure spirituality is important. If that's important in your life, you want to think about that and take care of yourself. Staying active. So obviously having epilepsy doesn't mean you can't be active. You might need to modify activities, but you can lead a full and active life. So activities, hobbies that you enjoy. This idea of mindfulness, what I always say with patients who I work with, trying to find how can you be in the present. One way is to find activities, hobbies, interests that you do. You become so absorbed in that activity and interest that you don't think of other things, that it's almost like your mind naturally clears. And it could be like painting, it could be like reading or playing music or whatever it is, something you get so absorbed in that you're just taken away into it. And that's important to find some activities like that. Socializing, mental activity, physical activity. And then obviously other activities that are important: exercise, nutrition, good sleep, relaxation. All of these things are going to help you to manage stress and cope. All the stuff that we're doing now, especially during this stressful time, people are doing these things more and really craving these kinds of activities. So what can you expect from stress reduction? You might have reduction in seizures, but you will have likely an improved mood and feel calm and satisfied and maybe peaceful and non-reactive, potentially better physical health, being in the present, having a good attitude about managing and coping with epilepsy. What you can't expect stressors to go away. They're always going to be there. You can't expect stress reduction to eliminate all your seizures, and it's obviously not going to take the place of medications that are important to take. So, in summary, and hopefully I'm pretty close to on time here. Stressors are unavoidable and can lead to depression and anxiety. Stress may be a trigger for seizures for some people, and many effective strategies to manage stress, including formal treatments, practices, daily life behaviors, can really help you manage stress. And though you can't eliminate stress, you can learn to cope with it. And that's all I have. Thank you very much for your attention. I'm happy to answer questions.
Hey, Dr. Tremont, thank you so much. Everything, including the mindfulness technique, I found helpful, and I hope people in our audience did as well. I'm scanning the question panel, and I do not see any questions, and I think that's because you left us in a state of bliss. So I think
great.
that's
Well,
key.
great to hear.
If you are willing, we would appreciate a copy of the slides that I'd put into a PDF form to share as handouts after the webinar, Dr. Tremont, and you could email that to either Christina or myself. But I really want to thank you for taking the time to speak to our epilepsy community today on this Friday afternoon. All right.
No problem. You're welcome, and thank you for having me. Take care.
You as well. Thank you so much. Okay, so our next presenter is Dr. Amy Morgan, and she's a specialist in clinical pediatric neuropsychology. She received her PhD from Suffolk University and did her clinical postdoctoral training at Children's Hospital Boston. Her clinical interests include the neuropsychological assessment of children with epilepsy, stroke, leukodystrophies, metabolic genetic disorders, and prematurity, in addition to the neurodevelopmental and learning disabilities. You can tell it's a Friday afternoon because my tongue is stopping. So she is going to speak on a topic that both she and I share. We both are very passionate about it. She's going to speak about resiliency. So changing expectations and learning to be resilient. So, Dr. Morgan, I do believe I made you the presenter.
Oh, you did? Okay.
Excellent. So I
Wait,
believe you
wait.
should be able to share it's saying waiting to view your screen. So if you just click the little, there
Show
should be
my
a dialogue.
screen. Okay. And you have
I
the
can see it.
slides?
Oh, do you want me to control the slides? I'm sorry, I apologize.
No, no,
do
I
have
don't
them.
mind controlling the slides. I just wasn't sure. I don't
Okay,
see
no, on this
anything.
one.
Okay.
Yep, I see your screen. So if you want to pull up your slides, that will be fine. If you would prefer me to
I
do that.
may not have my slides. I'm
Okay,
working
well,
now from home and my slides are on my work computer. Can you hear
I
me?
apologize. I can hear you. I
Oh,
apologize
good.
for that
Okay.
mix up. So I'm going to pull it
Okay.
back to me.
Thank you.
And I'm going to apologize to the audience. That was my drop in communication. So let me just quickly not share my screen so you can see and I will get those slides up momentarily.
Thank you, Susan.
My pleasure. Thank you. We'll just take another moment. We're in slideshow.
I can actually, oh, there we go.
Can you
Okay.
see my slide? Can you see my screen now?
I can see them,
Excellent.
yes. And I'll just
Okay,
say
so
next.
absolutely, and I'll do that
Okay.
for you. Take it
Okay.
away, Dr. Morgan.
All right. Well, I'm Amy Morgan, everyone. And I'm actually, I think that Dr. Margulies and Dr. Tremont gave incredible talks. And mine is really much along those lines, but with a focus on resilience, but resilience from a neurological perspective. So we can go to the next slide.
Oops, we should be in.
We do slideshow.
Yeah,
there we go. Okay, next. There we go. So I'm just going to go briefly describe what resilience is. The brain functions that underlie resilience, which actually have a lot to do with stress, which we've learned a wonderful amount about, and then how to build resilience, which we've also focused on a bit. But I think it's really helpful to have the same thing presented in slightly different ways because these topics are critically important. So next, so resilience, I think we all know basically what it is. It's the ability to thrive or do well in spite of what life throws at us. It's actually a concept, I think, that's fascinating that arises out of physics. And it has to do with the resilience of an object that will bend under stress, but then spring back and it won't break. But rather than break, it becomes more resilient. And people will spring back from adversity, just like an object under stress, and we become stronger in the process. And so the human brain, well, resilience used to be thought of as a quality that was possessed by very few people, these remarkable people who could bounce back no matter what was thrown at them. And it was a rare trait. But we now know through more study of brain and research that it's actually the human brain is designed, we are designed to be resilient. And that the trait of resilience helps ensure our survival, actually. One of the other things we know about resilience is that the human brain is designed to be resilient, and but in order to do so, our brains need social connections to build and strengthen our resiliency skill or our resiliency muscle. And what's important about the social connections is trust and encouragement from others, that we experience it from others and that they experience it from us. And I think that we need to talk a little bit about just what adversity is. Again, a concept with which we're very familiar, but it's just life's difficult circumstances, and it's difficult as we perceive them. It could be a health challenge such as epilepsy. It could be social or peer problems or just challenges, and it could be seen as we see it as being seen as different from others or not as good as others from our perspective. And so the takeaway message here is we're designed to be resilient. How do we tap into that? And that resilience can be learned and continually strengthened. So the next thing I'm going to talk about is how to build a resilient brain and a resilient child. We can go to the next slide. Now, just as by way of introduction, well, Susan actually did the beautiful introduction, but I do work with children. And this talk is designed originally for parents working or other professionals working with children, but it applies equally to us as adults, to any adult, actually. So for the purposes of this talk, I'm just going to divide the brain into three parts, and resiliency researchers do this. So the very lowest part of the brain, kind of like in the brain stem, the very lower areas, is what's referred to as the reptilian brain or the survival brain. And this is the first brain structure that was developed, and it's like a dinosaur's brain or a lizard brain. And it's our reflexive behaviors, our reflexive responses, that basic fight or flight. If you see something even out of the corner of your eye, your brain is built to respond fight or flight because our original survival depended on that. It was made when our brains and ourselves lived in the wild. It's not so suitable for managing modern human life, but it still is a very strong aspect of our brains. And I think we can all feel it, just that reptilian brain take over at various times. Then, our brains developed the limbic, the middle brain, or the emotional brain. And this is where the most important part, as I show on the lower slide there, is the amygdala. And it's a very tiny, tiny part of our brains, but it is so super powerful. And this is in charge of the amygdala as a part of our emotional brain, is in charge of reading and responding or interpreting and responding to emotional stimuli. So our amygdala and the little surrounding areas scan the environment for emotions. And it will be emotions that we may not even detect with our thinking, our logical brain, but our body responds to it. It could be something in an email. It could be an offhand remark we hear incidentally, but our amygdala is busy scanning, and reacting. When the amygdala is overstimulated, which can sometimes happen with certain types of seizures, and also just from experiencing distressing events over and over, each in various ways can contribute to an overstimulated amygdala. We then become our whole body, including our logical brain, becomes overly responsive to fearful, distressing, or even irritating stimuli. And it then makes a decision, without our logical brain being involved. Is this safe or dangerous? Should I approach or avoid? It's a little bit of a higher reflex in fight or flight. It's also involved in, can this person be trusted? Can the situation be trusted? What's really cool is the amygdala can be rewired, as can all of our brain. It's called neuroplasticity. And a cool thing about kind of amygdala type responses is if our brain decides that this person can be trusted and they trust me too, in the presence of this, our brain, not the amygdala, but other aspects of our brain release, I'm putting this in quotes, a feel-good hormone referred to as oxytocin. It's also a hormone that's involved in birth, when a woman gives birth, and it's a bonding hormone too, but it also contributes to forming relationships. And so it produces this oxytocin, which builds our instinct further for cooperation and closeness. So we have pretty complicated brains. And then we're moving up to our latest to form brain, which is the neocortex, or our logical brain. And this is where higher order functions lie. It's where we logical thought, problem solving, language is one of our incredibly higher order skills. Now, all of these we are going to focus on when we're talking about how to build resiliency. So next slide. Other way. The other next slide. Thank you. So emotionally charged, well, our memory, our brain stores memories. Our brain has a preference for emotionally charged events as opposed to those that aren't emotionally charged. And that is also for survival originally, because if we have to remember something that's safe or something that's a threat for our very survival when we were, humans in the wild, that's, I think, how our brain originally came to be preferring emotional events. Regardless, those are the ones that take precedence. And those become hardwired in our system. Now, nothing's all that high. Well, many things. It can be unhardwired, or we can have other things take precedence over these disturbing emotionally charged events. So emotional events have the most impact, and they're also the ones that take preference when going into long-term storage in our brain networks. Now, this wiring, not just for memories, but for all higher order thought and lower order, kind of more responsive brain networks, these talk to each other constantly. There's a wiring between each of these areas and brain networks. So the wiring, or the way by which information in our brain travels, connects these lower and higher parts. There are actually more connections, though, traveling from the lower levels up to the higher levels than there are from the higher levels going down. And what this means, well, it means a lot of things, but what it means for the purposes of this talk is that our lower levels carry a lot of weight, and in our ways in which we respond, in the ways in which we develop, even though we have these incredible higher order skills. And so when I'm working with children, whether they are typically developing, and teenagers, whether they are typically developing or have significant challenges due to their medical condition, I feel that it's always most effective to work from the lower levels up. So when these lower levels take charge, a body and the memories and experiences that we have are more negatively emotionally laden. Our body adopts a more stress-prone response to other events. And other events could be typically anxiety-producing, like COVID-19. For some people, including myself, it could be just uncertain or unfamiliar events. And our brain automatically or more automatically goes into the stress response. And our adaptive stress response, not optimally developed adaptive, but it might be aggression, it could be anger, it could be withdrawal. And if we don't want that, and we do respond that way because we don't perceive ourselves as being resilient, meaning that we don't perceive ourselves as being in control and capable of managing uncertainty or stress. So what do? Well, we can totally reprogram our brain. It is a process. It doesn't happen overnight. And the speakers before me went through a number of ways in which we can do this. I'm going to talk a little bit more about ways to think about how our brain responds before I get into the antidotes themselves. But we want to reprogram our brain, and we can use a top-down and a bottom-up approach, meaning our higher order cortex influencing our lower level automatic responses, and also reprogramming our automatic responses to make our cortex function more efficiently and to make the strategies we're learning, make them more effective. So next slide. So how do we move ourselves from a stressful way of being or living to a more relaxed, in control, and resilient state? Working from a top-down approach, which is kind of cognitive behavioral therapy, acceptance and commitment therapy, although I will say even those top-down approaches do employ working on relaxation strategies too. But many of us start with a top-down approach, which is perfectly fine, and we can use, and the most effective way in brain processes is using our verbal brain, which is in the left frontal cortex for most right-handed people. Regardless of where it lives in our cortex, we use our verbal brain to re-evaluate our responses using words, whether out loud or not, and then trying to ease our physiology by looking at things or understanding things in a different way. However, in some children, in younger children in particular, are those of us who may not find it so easy to access our language skills, especially when our brain is stressed out or when we have learning disabilities, etc. There is not easy access to this aspect of brain functioning. So we then work more exclusively on our physiological responses to stressors. So next slide. So we start by strengthening the survival and emotional brain responses, these lower level responses. We learn to, these are mindfulness, just as a hint, so you know. We become more aware of and diffuse, weaken our emotional arousal, meaning that, and a way to do this is to preempt over arousal. And for parents out there or people who work with kids out there, for children who just are having such difficulty with control, or ourselves, it's learning to become aware of even that little inkling of a feeling that, I'm feeling uncomfortable with this. And then we'll talk about strategies later, but addressing that before it starts getting out of control. When you're working with children, it's through over time, for the teachers and parents have probably learned this over time, to become aware of those first signals of stress in a child or ourselves and addressing them before they get out of control. And then it just, when a system, meaning ourselves or a child, is out of control, then you're beyond working with them and you're just controlling the anxiety, but you're not addressing the actual problem itself. And so you're preempting the over-arousal, and it can be even over-excitement, particularly in children. Do not use punishment. For children, don't use punishment. One of my favorite phrases for adults is the shoulds. Oh, I should be doing this. I should be feeling that. I should be better at this. I should be way less, way more, etc. So we don't want to should all over ourselves. That is our self-punishment. It causes a greater level of arousal, and it keeps us from working on becoming more resilient or less stressed out. Then we want to go towards strengthening resilience. So as both Dr. Margulies and Dr. Tremont both spoke about, we want to ensure that there are important people in our lives who are supportive, and important people in our child's life who are supportive, who we feel accept us, trust us, and whom we can have trust. We want to develop mastery over tasks, and they don't have to be big things. It's like when you want to change a big habit. You don't change the overall habit. You work on small pieces at a time to build successes. It's that we can use that strategy with ourselves. We can use that strategy with children, and for ourselves and for children. We want to provide motivating tasks, so a goal setting that's motivating for us, and breaking it down into steps that are just achievable, not super easily achievable because there's no growth there. And then we want to allow ourselves or help our child master the task with increasing ease until it becomes more automatic. What that's a sign of when it becomes more automatic is, of course, it's easier to use, but that is a sign that our brain is rewiring too. But we have to keep practicing and practicing to make sure that that rewiring takes hold. And what we're doing is providing ourselves or the child with a sense of control, that we are not simply a person that things happen to, that regardless of what happens to us, we can make choices. There are, for children, we provide consequences, not punishment for the actions, but we have a choice in how we respond. That means that we are more resilient, regardless of what life throws at us. So next slide. So I want to go back. Now, I presented this on my last talk for the Epilepsy Foundation back in March, what seems like a lifetime ago, but I'm going to revisit this briefly because people with epilepsy from a physiological or lower level of brain functioning, especially when onset is earlier in life, before adulthood, there are challenges that are often associated with epilepsy that also make us more vulnerable to stress.
Dr. Morgan, I'm not sure what happened. It looks like your mic is still on, but we're unable to hear you. I'm not sure if you had an interruption in your internet. Yes. Okay, I'm going to take a moment with the audience and wait for, it looks like Dr. Morgan has to sign out and sign back in because she's offline. I think she's had some sort of interruption in her internet service. This is the downside to the virtual world because we love our technology when it works, and we find it frustrating when it does not work well. I will check and see if anybody has any comments or questions. Oh, she's back. Excellent.
I am so sorry. That was my computer going down. I am so sorry.
No, you can't help that. I covered for you. No problem, Dr. Morgan.
Thank you so much. Thank you so much. I should have warned you that this might have happened. I don't know where it was that I stopped being heard.
So you were, okay, we were still on this slide and you were talking, you had mentioned that you spoke in March, a lifetime ago, and the reason you brought this back was that there were some important points to make.
Oh, golly. Okay. So these are things that people with epilepsy, especially earlier in life, before adulthood, these are things that may happen to our physiology. So it's good for those of us working with children to understand this. And these things that can be affected by virtue of having seizures earlier in life contribute to anxiety, to the sense of loss of control. And so for people working with children, this makes sense. For those of us, for the adults who are in the audience, I'm sure it's all adults in the audience, it might, and if you had seizure onset at a younger age, it might help you understand some things about yourself, and perhaps, and these are all addressable too. So just real briefly, motor system can be affected, and beyond the obvious ways of, losing the ability to use a limb, etc. The motor skills that can be more frustrating are difficulty controlling one's gait or ability to walk, controlling speech or articulation, so making it difficult to be understood, which has nothing to do with intelligence, and movement strength, how to titrate the strength of one's movements. The visual system, in addition to nearsightedness, farsightedness, there's functional vision, which often affects kids, particularly those who have very frequent seizures. And that's functional vision is referring to, first, perhaps the ability of the visual cortex, or the part of the brain that interprets the visual signals coming in. So the child may not be interpreting what they're seeing in the typical way. And then it also refers to the ability to control and shift our gaze or scan the environment or materials properly, which could mean that you're not taking all information in appropriately from the environment. And it could mean that even affecting things like reading, that you're having difficulty moving your gaze in a steady way across a line of print. So then somatosensory processing is basically just sensory processing, how we interpret, how our brain brings in and interprets sensory information. It might be touch, taste, color, light, sound. And if you're overly sensitive or undersensitive to these things, it affects your ability to inhabit and function in the world in a quote unquote typical way or in an easy way. Proprioceptive skills, which are just your body's position in space. With some young children, they might not understand, like they might understand what putting your hand behind your back means, but they may not be able to do it. So that ability to control their body or understand where their body and the parts of their body are in space. And the vestibular system, which controls basically our sense of balance and coordination. And so we'll go to the next slide and continue on with this. And attention is very difficult when in many people with epilepsy, because attention networks are spread throughout the entire brain. And if our brain isn't fully functioning, all aspects of it, it can affect our ability to have, peak effectiveness of our attention. And of course, social skills, social interaction is important for resilience. And it's just referring to our ability to relate to, communicate with others, and make sense of our social world. Language, all aspects of language are important, including understanding it, and then the ability to express ourselves easily, often with earlier onset of epilepsy, or when epilepsy is in the dominant or language hemisphere, there can be difficulties, particularly with finding words, even though they're there, but just getting them out. and organizing or formulating what you want to say. And then just the coordination of visual and motor skills, which basically is writing and drawing and motor planning. So next slide. Also, what I talked about back in March was the fact that our brains can develop our different skills, that is, which can be due to disruption by seizures, but it also can be due to things like having attention deficit or other just kind of developmental upsets. Our brain skills can develop at different levels, meaning that we could, so for a typical adult or say a typical 10-year-old, we may be very bright as measured by IQ tests, but our ability to use our smarts can depend on our ability, on our level of stress or stressors in the environment. Our ability to pay attention can affect our ability to use our strong skills. We may have, and children may have, emotional meltdowns that are more typical of like a 3-year-old's meltdowns when the child is perhaps age 9 or 10, or when we're adults. And so kind of honoring that aspect of a child's physiological functioning and also our physiological functioning. If we are 30, 40, in my case, 60 years old, and we sometimes act as maybe a 12 or 13-year-old in some instances, just kind of honoring that and know that we can address that child within us, that childlike response in us to develop. And in children, we can do the same. So next slide. So basically what I've been saying is that when our brain systems don't work well, and when we don't have the ability to easily adjust to new situations, our anxious circuits or our stress circuits, that muscle becomes very strong, and it blocks to some extent our logical brain from working as well as it could. So what we want to do is strengthen those basic brain systems built in terms of relaxation and building up our sense of control. And that will strengthen our ability to be in control and our brain, our higher order brain's ability to use its skills most effectively, which is otherwise known as resiliency. I think I might have run out of time, but so what to do? So real quickly, next slide, for these lower level functions such as vision, social skills, etc., I would recommend for children getting these supports because we want to kind of address the lower level skills in order to address the higher level skills more effectively. So therapies, parent training can be really good, and it's called parent-child interaction therapy, and it's not like the parents really need training, but maybe parents need help in developing the most positive, adaptive strategies to help their child develop their lower level fight or flight response skills and develop more adaptive behaviors. There is applied behavioral analysis, which is basically just breaking tasks down into steps. And as Dr. Tremont described, cognitive behavioral therapy has been very well researched, and that also applies to acceptance and commitment therapy, which actually the International League Against Epilepsy backs acceptance and commitment therapy, which is basically CBT or cognitive behavioral therapy with a stronger mindfulness component to it. And then I'm going to skip. Okay, so next slide and next slide and next slide. So reducing anxiety in the classroom, I want to talk about for a bit, just because I've been dealing with a lot of school meetings during this COVID-19 social quarantine, basically. So everyone's being educated at home thus far. And I have had a window into, more of a window than I have had in the past, into classrooms. And I think the teachers are doing an amazing job, But I've also found that, and I knew this before, but I found it even more, that too many students have learned and experienced the classroom as simply anxiety promoting. And it's really, it's I think due to a bad fit between the student and the classroom or teaching method. And so as a result of this, and we can think back to our own childhoods and challenges as grown-ups, our brains, or the students' brains, have become programmed in an adaptive way, actually, to resist authority, to resist new instruction, to act as though they don't care, or act out, and to feel, because they feel, that whatever they try just won't work, that the response won't be supportive. This is not a natural state for our brains to be in. So what do we do about it to rewire this? And forgive me if there's no one who has children to work with in the audience, but I just feel this is important, that what we want to do is have at least one person, and one really important person for the child, who understands the cognitive profile, the emotional profile, the medical condition of the child, who can also be calming, supportive, and empathetic. They really get it. They don't have to have had epilepsy or learning challenges. They just have to be able to get it. They have to be present and help the child develop these coping and learning strategies. But first, the coping strategies that that we've gone through, and that the other speakers have too. Then encourage the child to be mindful, which means just being self-aware and using language when possible to talk about stress, to name these things, which gives us control. Naming gives us control over these things we're feeling. Naming the stressors, what we're feeling, the outcome of the stressors, anxious, angry, shy, sad, etc. It helps the students and us, if we're using this approach on ourselves, recognize what it is we're feeling, and building empathy for themselves and for others, for ourselves and for others. So being mindful, and then going into teaching kind of really executive functioning strategies. It can be, I think, time management, organization, how to be flexible. And then with the teaching staff, helping them learn to award or reward the child or ourselves for developing these skills that may not immediately show up in grades, but that these are actually more important skills for life. Developing risk-taking, developing trying, developing persevering, developing self-control. We should all be giving ourselves and kids A's for these things, because these are the most important skills. And Susan, should I stop talking now?
How many slides are left, Amy? I forget.
3, basically. I'll go through them really quickly. Intervention studies show really good things. Next slide. And the interventions can be music, social groups, occupational therapy, play, etc. The 2 that are most important in my mind are mindfulness, which show increasingly promising results in terms of not just improved self-control and seizure control, but they also strengthen related brain structures and networks, most prominently, wait for it, the amygdala. And so the amygdala is actually strengthened by mindfulness if you do it in an appropriate way. And yoga is also another skill, or another practice, I should say. I would recommend something like Hatha yoga, which is easy. It really focuses more on flexibility. and mindfulness and relaxation than the more vigorous yogas. But that also has been proven to can regulate stress, anxiety, improve mood, can lead to seizure reduction and improvements on EEG. So in summation, we can take, and social groups, again, for the same reasons. Okay, next slide, last slide. So we want to develop a resilience so that if we're thinking about our children, then we want to develop resilience ourselves so we can model these behaviors for our children. We want to provide supportive relationships, strengthen self-regulation, and build perceived control, because it is not about what life throws at us, but it's how well we bounce back and become stronger as a result. Thank you.
Oh, Dr. Morgan, thank you so much. And who doesn't love Tigger? Always the eternal optimist, having fun. Thank you so much for... We appreciate you spending time today, and I believe you gave me permission to create a PDF from these slides to share with the audience.
Absolutely.
Thank you so much for spending this Friday afternoon with us. So I am now going to share my screen with our next speaker, whom I'll introduce as soon as I pull her up and give her the ability to share her screen. So Rose Chayette is the Director for Community Education and Outreach with Samaritans Incorporated. In this position, she oversees a team that teaches suicide prevention workshops to youth, adults, and elders throughout the greater Boston area, and delivers these workshops herself. The team provides about 600 suicide prevention workshops a year, reaching approximately 20,000 people. Rose has been in this role for 4 years, and prior to this, she spent 2 years answering calls and texts on the Samaritans Helpline. Previously, Rose worked for the U.S. Department of Labor and served in the Peace Corps in the Ukraine. So Rose, I'm happy to have you join us, and I want to inform the audience that I gave you the impossible task of taking an incredibly rich and detailed hour-long presentation and asked you to make it 30 minutes. So take it away, Rose.
Thanks, Susan. Just want to make sure, can you see my screen and can you hear me all right?
Yes, I can.
Perfect.
I'm going to assume that because I can, everybody else can too.
All right, well, let me know if anyone reaches out that they're having any trouble seeing it or hearing me. So yeah, thank you again. I'm really glad to be here today. And I know that it's been an afternoon full of a lot of, jam-packed full of information. So I really appreciate folks sticking around for my portion of today. Before I dive into the slides, I want to just say a couple of quick things. First off, this is a really heavy topic. I don't know if anybody participating today has been impacted by suicide, whether you've struggled yourself, whether you have worked with someone in a professional capacity, whether someone in your life has had thoughts of suicide, or maybe someone out there actually has lost someone to suicide. So because it is a tough topic, because I don't know who we have out there participating, I just encourage you, if it's bringing anything up for you that's challenging or upsetting, feel free to take a break. And if anybody wants to reach out to me after and chat about anything, please feel free to. My email will be on the last slide. As Susan said, this is this is a topic that we are just going to be barely scratching the surface of in this next half hour. We could talk about it for so long. So because we're only just diving in the tiniest bit, I encourage you to reach out to me again if you want more information, or if you just want to learn more. There's so many resources online you can dig into, and I'm happy to share more as well. And we're going to be approaching this topic from the perspective of, if we find ourselves supporting someone who's at risk for suicide, it could be a family member, it could be a friend, it could be a colleague, could be anyone. So why don't we dive in? So I just want to briefly share about a couple of our Samaritans programs. I think people that have heard of Samaritans usually have heard of us for our intervention service, which is our crisis services. This is our 24-hour helpline, which can be called or it can be texted. And during this COVID-19 time, all of our programs we're doing everything virtually, as you can imagine, and our helpline is still very much available by calling or by texting 24 hours a day, 7 days a week. This resource is free, it's anonymous, and it's confidential. And I do know that sometimes when people hear about a helpline like ours, often one of the first thoughts is, oh, it's a suicide hotline, so therefore it really must only be for somebody who is in that really dark place, who is thinking about suicide. And yes, of course, we get calls, we get texts every single day from people who are contemplating suicide, who truly are in a crisis. But we actually have more people reaching out who aren't in that place, but they're really struggling, whether it's a breakup, whether it's dealing with isolation, whether it's parents divorcing if a young person is reaching out, whether it's someone who's extremely anxious. I mean, someone who's dealing with a loss, really whatever is going on in life, we want to be there 24/7 to be able to support them. All we do on our helpline is we show compassion, we show empathy. We don't we don't give any advice whatsoever. We ask questions. We just try to really give that person who's reaching out space to talk, without any judgment whatsoever. I do want to say that if we are speaking with someone, and this is something that I think is valuable for everyone to know in case you find yourself in this position where you are speaking to someone who shares that they're thinking about suicide, a couple things we try to do on the helpline, I think, go against what we might naturally feel inclined to say to someone who is in this space. So for example, if someone shares with me that they're thinking of ending their life, I might feel inclined to say to them, you have so much to live for. And that is a really common thing to say and to want to say to someone, because they're down here in this dark place, in this hole, feeling totally hopeless, totally helpless. So I want to pull them out of this hole and say, no, I know you're feeling this way, but think about all these positive things you have going on. You have so much to live for. We want that person to think about it, but they're not in a space in that moment to actually think about those positive things that there might be. They don't feel that there's anything to live for. So I'm not going to put that onto them. I'm just going to listen. I'm going to show that empathy, that compassion, and maybe through our conversation, they might be able to pull themselves out of that hole themselves rather than me trying to pull them out, if that makes sense. We also try to avoid saying things like, oh my gosh, think about your friends, think about your family. And the fact is, a lot of people who do think about suicide, they actually are thinking about friends, they are thinking about family, but they're really feeling like a burden, and they're really feeling like everybody is just better off without me. So these are some things that I think are worth mentioning, because again, I think they go against what we naturally are inclined to say to someone who shares these thoughts. So we have a couple of programs for time purposes. I'm gonna skip talking about them, but please, go to the Samaritans website if you want to learn more about our other programs, and if there's time, I'll mention more at the end. So very briefly, I'm going to share a couple of statistics. The problem with sharing statistics about suicide is it kind of can paint this topic sort of black and white, a little bit, in a simplistic way, when it's really not simple and every situation is so different. That number in the top left-hand corner there, just over 47,000, that's the number of suicides that were reported recently. That does not actually reflect how many suicides do take place year to year, because sometimes there are suicides that aren't reported that way. There could be a drug overdose, not reported as a suicide. There could be a car accident that was a suicide, not reported that way. We just don't know. Unfortunately, those numbers do seem to be going up. For those that are from Massachusetts, you can see we have this is what our rate is, 638. It's obviously far too many, although we have one of the lowest suicide rates in the entire United States. Right now, the highest suicide rate is amongst adults aged 45 to 64, although it is the second leading cause of death for youth. So, again, sharing statistics, it's not my favorite thing to do. It does paint it a little bit black and white. However, I think it's important to share a couple of these just to make sure that everybody is on the same page, and also sort of understanding that this is a public health crisis that we're just not talking about enough. I think we're talking about it more than we used to, but still it is highly stigmatized. A lot of judgment and discrimination comes into play with the topic of suicide. There's often a lot of fear that if I talk about suicide, if I ask someone directly, are you thinking about suicide, that I might be putting that idea into their head. And that's actually false. Talking about suicide with someone who is struggling with those thoughts, asking the question directly, can be a huge relief for someone who is really struggling. You know, we ask every caller, every texter on our helpline if they're having those thoughts, and people really oftentimes express relief and feel just really glad that the question is being asked, you know, without judgment, so openly. And I know that, you know, in a half an hour webinar, I can't imagine anybody who's listening right now is going to walk away feeling 100% comfortable with this topic or asking this question. What I do hope is that what you would walk away with is just feeling a little bit more empowered to know, okay, if I'm worried about someone, if maybe I'm seeing some warning signs or something seems off, or I just have that gut feeling that someone's really not okay and is truly in a dark place, I can dive into this topic with them, and I'm not going to influence them to do something. I'm not going to place an idea into their head. I actually may be opening up a conversation that they are so desperate to have with someone. So that's kind of one of my hopes for this webinar today, for everyone who's out there listening. In terms of the second bullet point up here, you know, there's often talk of, you know, are there warning signs? Do we know if someone is feeling suicidal? Do we know if someone's going to make an attempt? Sometimes we have those warning signs, sometimes we don't. There's not really like a true yes or no to this topic. There's some data out there to suggest that about 70% of the time there are warning signs, but not always. And the fact is, and this is a really common occurrence that I've heard of so often, which is that a person dies by suicide and people are coming together and in conversation are realizing, you know, this person over here saw a change in the person but didn't really think anything of it, and it was just, you know, one isolated situation or event. But this other person over here saw another change, and then this person over here saw something completely different, and, you know, on their own didn't think much of it, but put together really paints a picture of, wow, this person was really struggling. But, you know, we can't be held responsible for information we didn't have. We can't be held responsible for that kind of thing. So it's really a tough topic, tough thing to discuss with the topic of suicide. My thought is the best that we can do is just be aware of what some of those warning signs might be in case they are presenting, and then also be willing to take that next step, which is, okay, if I'm seeing a change, I'm going to have a conversation with this person to see if maybe something is going on. And in terms of the third bullet point here, I think a lot of people get worried, you know, I'm not a professional, I'm not an expert, I don't know how to help. And I want to mention that on our helpline, we actually have volunteers answering our helpline that are as young as 15 years old. I mean, these are high school kids who go through training to learn how to engage with and talk to people, sometimes who are at a very high risk for suicide, and they do it. So I think that, you know, that in itself just really goes to show that we don't have to be a quote unquote expert, as long as, you know, we have that willingness to be a good listener, be compassionate, get that person some help, go through some steps to learn what to do in these situations. But really, we don't have to be an expert or a professional. Anybody can help someone who is struggling. This is, you know, suicide is a really complex topic. I think sometimes it's presented in sort of simple terms. Like, for example, you know, I don't know about anyone out there listening, but I sometimes have heard stories in the news where they say something like, a boy was getting bullied in school, so then he took his life. and it's kind of presented like the bullying was the direct cause of the suicide. This one life situation, this one hardship led to the suicide. I'm not diminishing how painful bullying can be, but at the end of the day, it's never really just one thing that is leading someone to think about suicide. It's usually multiple factors, and we can call those the risk factors. These risk factors that I have up here, this is not all of the hardships, challenges, difficulties, stressors, or traumas that a person might face. This is a small sample of what some risk factors may be. But again, not one of these individual risk factors causes suicide. But if we have a person who is facing a whole number of risk factors, and maybe on top of that, they don't have a good network of support, maybe they don't have good coping skills, maybe they have a mental illness. Not everybody who dies by suicide is depressed or has a mental illness or has a diagnosable one. And maybe a real sense of hopelessness starts to set in. So if we imagine a person, like I said, they have a lot of risk factors, they feel helpless, they feel hopeless, they don't have support, they don't have good coping skills. If all those things are piling up, for some people, it can really start to feel like too much. And maybe they start to feel like this is so much that I just don't know how to deal with this anymore. I don't even want to be here anymore. And they might start to have those thoughts of suicide. I want to mention that, I don't know, admittedly, a ton about epilepsy. I'm learning more about it. And those, epilepsy, seizures, absolutely a risk factor, as, many physical health conditions are. And some studies have shown that there are higher rates of depression and anxiety. And I know some seizure medications as well sometimes have a warning that a side effect could be increased thoughts of suicide, although I have read that some people have questioned if there are underlying conditions that might be present. So, a lot is unknown about this topic in general, but I wanted to mention, because the topic is epilepsy today, that would be an additional risk factor. So, like I said before, we don't always have warning signs, but I think it's good to be aware of what some of those might be in case they're presenting. They generally fall into these three categories here. People do verbalize suicidality. Probably it's not as common to verbalize as some other warning signs might be, but people do. And it's not always really explicit. It's not always right there in our face. It might be someone saying, what's the point of all this? I don't even, I don't want to do this anymore. Well, that's kind of a vague statement. If I heard someone say a statement like that, I would probably want to dig in a little bit deeper and ask sort of like what they meant by that. People, adults, kids, seniors, like people also, regardless of their age, make jokes about suicide. I've heard jokes about suicide. I can admit that before I started doing this work, I think I've been guilty of making a joke, I was stuck in traffic, I just wanted to kill myself. People make jokes all the time. If I heard a joke about suicide, I would maybe pull that person aside and I would say to them, hey, I heard that joke you made, or I heard that comment. I kind of take those things really seriously when I hear it. Are you really having those thoughts? Is something going on? That might sound really uncomfortable and really awkward, but I would rather make a situation kind of uncomfortable and kind of awkward by digging in deeper with that person than tiptoe around it and avoid it and then think about it later on and say, gosh, they made that comment, they made that joke. Was there something there? So I just don't think it ever hurts to check in with someone, whether it's sort of an offhand comment or a really serious comment that is a little bit more clear of the fact that maybe they're struggling. Physical changes, weight, appetite, hygiene, sleep, changes in sleep patterns. You can see a lot of these are behavioral changes, withdrawal, loss of pleasure and interests or hobbies, extreme mood swings. If I had a person in my life and I was seeing a change, I would talk to them. I would say to them, hey, I might be wrong, but I've noticed that you seem a lot more tired than what I've known about you. Or I heard that I saw that you sort of haven't been, I know things are different in COVID times, but, sort of just whatever the change is that you're seeing, putting it out there and acknowledging what you're seeing and asking that person, is there something going on? Is there something to that? And if they're really struggling, like this is kind of meeting them in the middle. It's you coming forward and saying, I see you, I see this change, I am worried. And if they are really struggling, that's probably going to feel really good to them. It's going to feel really good that they were noticed by you. So that's what I would do if I were to find myself in this situation. And now I know because we're not together right now and there's a lot of physical distance between us, we can ask these questions to try to identify if there are some warning signs if we're not physically with the person. So maybe we can't see what their day-to-day is like, see those changes, we can still inquire into it. So just like, everyone has different risk factors in their lives, people show different warning signs, people also have different coping skills and different levels of resiliency and these risk mitigating factors. If we were all together right now, face to face, doing this workshop, I would have every one of you write down your personal coping skills. I think it's a good idea to almost do an inventory of what are the things that help me and what are the things that help me now that, we can't, not because of COVID-19, we can't necessarily turn to the coping skills or do the same things that used to help us. So kind of having to pivot and find some new ways to cope. I think it's really important to take that time. If I was speaking with someone who seemed like they were really struggling and maybe they weren't really taking care of themselves and maybe they didn't really seem to have a lot of coping skills, I would want to try to help them. I think our first instinct sometimes is to say to someone, oh, it seems like you're really struggling. Hey, why don't you, try to get some fresh air or try meditating or, listen to some music. Those are things that help me. And that can get a little bit frustrating when you're struggling or like when you're struggling and someone says to you, oh, do this, do that, and starts to try to fix it for you. That's not always what the person needs. Maybe they need some guidance or some assistance brainstorming coping skills, but we all cope differently, and it can be irritating when someone says, oh, just do X, when we're different people and X may help you, but it may not help me. So just one thing to keep in mind. So the last portion of this webinar is what we can do to help someone. We've got 3 categories: listening, asking, getting help. Listening is so important. We want to let this person express their feelings. We do not want to judge them whatsoever. We want to put away distractions. If we're talking face to face, we definitely want distractions away. But if we're, over Zoom, over FaceTime, on the phone, yes, we still want to put away distractions. We want to be fully engaged in that conversation. Even having that open body language is possible while we're not physically together. Repeating back what you're hearing, showing you're present, making eye contact. These are all things, and at the end of the day, I can acknowledge these things are pretty self-explanatory. Like, it's pretty obvious. Oh, you're talking to someone, put away your phone. Oh, you're talking to someone, make eye contact. However, I think it's worth it to reiterate these points because, if you imagine someone who is really in a dark place and they're really struggling and they have not felt comfortable opening up to anybody, and then they open up to you, but they feel judged by you, or they feel like you're not really listening, or they feel like you're kind of, trying to change the topic. That's going to be so hard for them. So I think that's why it's important to kind of think about, how do I really show somebody that I am truly listening? How do I give them my full attention to really be able to help them? So I do want to say with these first 2 bullet points up here under the don't category, just imagine there's a little star next to each one, because I am not saying that we should never talk about ourselves or reflect on our experiences. I'm not saying we should never give advice or try to help someone. The thing that I want to point out is that very often when we speak with someone who is struggling, our first instinct, or pretty early on, we have the desire to say, oh, I completely know what you're going through. And then we kind of talk about our experience to, help validate. We want them to not feel alone. We want to show empathy and say, hey, I have been there. I get it. Depending on the relationship you have with, that somebody we might have with this person, there definitely can be positives to sharing that personal experience to help that person not feel so alone. However, it can be frustrating, if I'm trying to open up to someone and they just keep saying, I get it, this happened to me, but actually I'm like, no, you don't get it. We're different people. I'm going to perhaps shut down a little bit. I might not even feel comfortable going back to that person to open up because I feel like they didn't really listen to me. They made it about themselves. That's kind of one of the things to think about. And secondly, with, the second bullet point here, giving advice, if someone comes to me with a problem, I want to fix their problem. I don't want them to be in pain. I don't want them to struggle. But maybe they don't want advice. Maybe they just need to vent. Maybe they, want to tackle this problem on their own. Maybe they're not ready in this moment. But me sort of laying on that advice, it's going to feel overwhelming. It might feel frustrating. And the fact is, if I'm really trying to listen to someone, but then I start giving advice, I'm kind of going down a different path. I'm not even really listening to them anymore because now I'm trying to solve their problem. So it kind of inhibits the listening because I'm just trying to solve it. So just a couple things that I think are worthwhile to keep in mind. If we're listening, we have to ask open-ended questions that begin with what, with how. We try to avoid why questions at Samaritans because asking a question with why can kind of carry some judgment. They might not know why. Why are you feeling this way? Why did you do that? It starts to feel like an interrogation. So trying to reword a question to avoid the why, I think it can be pretty valuable. And to this last bullet point here, I want to point out that no matter how well we know a person, no matter how much experience we have having difficult conversations, everyone is going to reach a point in a conversation where they feel like kind of at a loss for words. I have situations where I'm talking to someone, they're sharing something really difficult, and my mind goes a little bit blank, and I'm like, oh, where do I go from here? What do I say? It's kind of awkward. If that were to happen, it's okay to say to someone, I don't even know what to say right now, but I'm so glad you came to me, or I'm so glad you opened up to me, or my gosh, I'm at a loss for what to say. I really am, but please tell me more. I'm listening. Those are really compassionate, kind. It's honest. This is an honest thing to say, and that might be more compassion and honesty than they're used to getting from anybody. So it's okay to express that if you're finding yourself at a loss for words. So if I'm speaking to someone, I'm listening, I'm asking questions, maybe I really have seen some warning signs, or maybe I know a lot of risk factors in this person's life, or maybe this person says to me, ugh, if I just didn't even wake up tomorrow, it'd be better for everybody. Maybe I just have that gut feeling. Regardless of what the scenario is, I might feel like I want to and need to dive in a little bit deeper to assess what's happening with this person. So I'm first going to say to them, probably thank you. Thank you for opening up to me. Thank you for talking. It seems like, I hear how much you're struggling. I hear how much pain you're in. And I want to check in. Do you sometimes feel so bad that you think about suicide? Or do you wish you could go to sleep and not wake up? There are different ways to ask this question. Personally and with Samaritans, we like to use the word suicide. That's mostly because it breaks down stigma. It puts the topic front and center. It is not beating around the bush, but there are different ways to ask this question, certainly. The point is just that it's asked very straightforward. This is not one of those open-ended questions. This needs to be a straightforward with a, looking for a yes or no answer to really be able to find out where this person is at and how they're feeling. If the person says no to me, no, I haven't been thinking about suicide, I'm probably going to feel relieved. I'm probably going to feel like, oh my gosh, I'm so glad they're not feeling this way. I would recommend sort of not expressing that relief though, because if someone says to me, no, I'm not thinking about suicide, and I say, oh, I'm so glad, what if they are? What if they actually lied to me? You know, we unfortunately can't force people to always tell the truth. And now I sort of am saying to them, I'm not someone you can really come to with that in the future. So if I got a no to that question, I would say to them, thank you for telling me that, and let's keep talking. Now, the thing I'm going to share on this next slide is a little bit high level, I guess you could say. It's more that I want everyone to know that it's okay to ask questions. It's okay to dig in deeper if you get a yes. This is what we do on our helpline. This is what a lot of clinicians do, just people in general do. If they find out someone is thinking about suicide, they dig in deeper to find out, you know, where on the spectrum of suicidality are we? Are we over here on one side with a person that has ideation, that has thoughts, or are we way over on this other side and they actually have a plan? So these questions up here, again, it's a little bit high level, but it's just to help you understand and know that it's okay to ask these questions if you are comfortable. One thing I will mention is that sometimes people reach out to our helpline with someone who is struggling so that we can help with that risk assessment. That can be a nice thing just to do, because imagine, you know, it's really hard. It can be really hard for some people to reach out to a helpline. It can be scary to ask for help. It can be scary to, you know, be honest and be open about feelings and thoughts. But sometimes having someone there saying, hey, I heard about this number. I don't know what's going to happen, but do you want to give it a text and I'll be here with you? Or do you want us to give a call together and we'll talk to them? That can be something that's really comforting for someone who is struggling. You know, I really feel, and I'll be finishing up in just a minute, I really feel that if someone's life is at risk, that's a lot to carry on your shoulders. It can be really hard if someone is coming to you disclosing thoughts of suicide, asking you to keep that a secret, pushing back against getting help, but it's just so much to carry this on one person's shoulders. So I just think it's really important to reach out and get some help, whether it's a doctor, a therapist, going to a hospital. You know, sometimes going to a hospital, sometimes calling 911. These don't always feel like the best options or the safest options, but you know, it's just something to think about. Is if someone is really in an imminent risk situation, if someone's life is really in danger, these might be the best things to do. If it's a workplace, following protocol, working together, engaging in self-care is also so important. And if I'm talking to someone who shares with me that they've been thinking about suicide, I'm going to do my best to stay calm. Now, that's not always possible. It's not always easy to stay calm when someone shares this. I might be filled with anxiety and fear. I might start to really like creep up to a level 10, but this person who's talking to me, they're probably already up there. They're already really struggling. And if they see that I'm, you know, my anxiety, my fear is coming up here to a 10 as well, it might be harder for them to deal with the situation. So I think trying our best to stay calm is an important thing to do in those moments. Also, giving yourself permission to be human. Know that you are not alone. There's people in the community that will help. Being mindful of our limitations. And this is a really hard one. This is the third from the bottom bullet point. You know, we can't control anybody else. If I'm worried about someone, I want to chain myself to them and keep them safe, 24/7. That's not possible. And because we can't control anybody else, because we can't, you know, control anybody else's actions but our own, we can't always help everybody. That's a really hard thing to grapple with. I've certainly had situations when I was a helpline volunteer on the Samaritan's Helpline where I had to grapple with difficult situations and not know if somebody was going to be okay or was going to be safe. It's just the reality that we have to deal with sometimes. So something that I always think is hard to mention, but important to mention. You know, I think we all have a role to play in suicide prevention. And again, we might not always be able to help everyone, but we can do our best to support them. I can't emphasize enough the importance of active, non-judgmental listening, and that it really can go a long way for someone who really feels like they have no one who truly is listening to them. And this is a really important final thought. You know, for many people, not all, but for many, many people, thoughts of suicide are temporary, and with time and support, they will pass. And that's one of the things that, you know, sometimes I think is why it's so important to maybe bring someone to a hospital or make a call to 911 or call a helpline like ours, because if that person can get some help in that moment during that crisis, there's a very good chance that they will be okay in the future. And so I think that's an important thing that I always want to mention. If speaking is silver, then listening is gold. I like that proverb. This is our Samaritan's Helpline. I'm going to keep it up here for just a second, and then I'll bring up my last slide, which has my my email and my contact information on it. And, you know, this was a heavy topic. I know I shared a lot of information this last half hour. Please feel free to reach out to me, shoot me an email if you would like any more information. If you go to my organization's website, SamaritansHope.org, you'll find a lot of information. And, you know, please on this Friday afternoon, engage in some self-care. You've learned a lot this afternoon, and again, this was a heavy topic, so please take care of yourself. And I think with that, I'm going to turn it back over to Susan.
Rose, thank you so much. It is a heavy topic, but we felt it was important to bring it in as part of our mental wellness, because it does exist, and it doesn't do any good to just hide from it because it's a heavy topic. So thank you so much for really very clearly. I appreciate the tips of, this is why we're asking these open-ended questions, and you've given us the verbiage to use. And then at the end saying, okay, if someone's in imminent danger of this, we're gonna ask these yes/no questions because we need a hard answer at that point. I find that invaluable, and I hope other listeners do too. As I scan the panel, I do not see any questions for you, but I am going to tell the audience that we are sharing all of these resources, that I will send out PDF of handouts of all the slides so that you will have these resources at your fingertips. So Rose, thank you so much for taking time out of, as a young mom, Rose has a baby. I'm going to disclose on you, Rose.
That's okay.
So,
thank you.
taking this time out on a Friday afternoon, I truly, truly appreciate it, and want to thank you for joining us.
My pleasure.
Okay, so I want to thank all of you for taking time to spend a Friday afternoon, particularly on such a gorgeous day where I think we all should be basking in the sun because it's not too hot. And I want to take time to thank so much our presenting sponsors, Greenwich Biosciences and SK Life Science. And a thank you to BioCodex again, ASI, Neurelis, and UCB for their sponsorship. This makes these programs helpful. When I close this webinar, a survey will automatically go out. If you have the time, please complete it now. Otherwise, I have it set up to come out 24 hours later. So if that would be better for you tomorrow to answer it. So either way, I want to thank you. I hope you all have a wonderful, wonderful Friday afternoon and the rest of your weekend. Stay healthy, stay well. These are certainly strange times we're experiencing. Enjoy your weekend. Goodbye, everyone.